AMI, acute myocardial infarctions. All right. Since Dr. Shanti Naidu brought it up Friday before, I thought we should get into this. I've sent you a PPT which I'm not presenting. You got it? On carbohydrate, metabolism, diabetes, more or less an overlap of the first lecture. So you can refer to it. All right. So we will revise this very quickly and get into the algorithm. So you all know Trop T, a regulatory protein released when cardiac cell necrosis occurs, right? The deadening of the cells occurs. And you've got a Trop I, a Trop C, and a Trop T. And I'm giving you the positions. All right. So you've got something like protein called tropomyosin. You've got head to tail overlap of tropomyosin, and you've got actin. So we've got this little cartoon on the right hand side. So it's a troponin is a complex of 3 regulatory proteins that is integral to non-smooth muscle contraction in skeletal as well as cardiac muscle. Troponin is attached to the tropomyosin in the process between actin filaments in the muscle tissues. These subunits are there as you've got C, T, and I. All right? So the background is as follows and how it came around. Patients with symptoms suggestive of acute myocardial infarction account for approximately 10% of all emergency department consultations. The 12-lead ECG and cardiac troponin form the cornerstones of the diagnosis of acute myocardial infarction and complement clinical assessment. A limitation of the former generation Trop T assays is the inability to detect low levels of Trop T and the associated need for prolonged serial sampling for 6 to 12 hours. Now that was the older one. Okay, so you have to keep, the patient has to sit and their decision is made. Delays in diagnosing disease, rule-in delays as we call them, hold back prompt use of evidence-based therapies because this is one dysfunction that needs to be treated immediately. And the 6 to 12 hour delay is not advisable. Delays in excluding acute myocardial infarction, rule out delays, interfere with evaluation of alternative diagnosis and contribute to medical errors and costs associated with crowding of the ET. So high sensitivity cardiotroponin, Trop T assays, which allows measurement of even low Trop T concentrations with high precision, have been shown to prove high diagnostic accuracy for acute myocardial infarction already at presentation levels. In parallel, several early rule-out strategies have been developed. These include the use of very low concentrations of Trop T as well as combination of Trop T concentrations at 0 and 2 hours with clinical score. Limitations of these approaches include that they do not provide guidance for rule in and rule out is possible only to 10 to 40% of patients. So we have to provide a diagnosis to the doctor in time and a quick time. According to high sensitivity troponin T, the 0 and 1 hour algorithm has received substantial attention. Keep that in mind. The algorithm uses Trop T, blood concentrations at presentation, and the absolute changes within 1 hour of triage patients, the patients who are admitted. It was reported to achieve a very high negative predictive value for acute myocardial infarction in the rule-out zone, to achieve a high positive predictive value in the rule-in zone, and to be very effective by triaging approximately 75% of patients presenting with suspected acute myocardial infarction to the emergency room, to either rule out or rule in. Obviously, successful external validation in a global and meticulous multi-center study is mandatory. So you have to have studies, you have to have data before such a novel approach can be considered for widespread implementation into routine clinical practice. So what was needed? Now to be really fine-tune this and make it very accurate, that's the question we are asking. An algorithm had to be developed. One needed to save the patient from unnecessary hospitalization and tests. The real ones had to be identified and treated. Now that is the main aim. An international multi-center study was undertaken to externally validate the diagnostic accuracy of Trop T 0-hour and 1-hour algorithm for the rapid rule out and rule in of acute myocardial infarction, and thereby evaluate its suitability for routine clinical care. As in all trials, stringent selection criteria were laid down about selection of patients, their history, sample collection methodology. None of the study blood results was available to the treating physician, so it's all like a blind. Study was not only in Europe based as APACE is, but include 12 sites, US, Australia and so on. Samples were blinded and run on Roche Alexis 2010 and a competitor for comparison. Study carried out by Dr. Christian Mueller et al. TRAPPID study investigators, and this is very interesting. The limit of detection was determined to be 3 to 5 nanograms per liter. An imprecision corresponding to 10% coefficient of variation was reported at 13 ng per liter. The 99th percentile of healthy reference population at 14 ng. The Trop T ultra-sensitive assay is reported to have limit of detection to 6 ng, a 99th percentile cutoff value of 40 ng, and a coefficient of variation less than 10% at 30% ng. What does the algorithm use? The Trop T 0-hour and 1-hour algorithm uses Trop T blood concentrations at presentation and the absolute changes within 1 hour to triage patients. So as soon as the patient comes and says, I have chest pain, it starts. To rule out status, the observational zone or rule in status, patients with Trop T below 12 ng and delta 1R below 3 ng to rule out status. Trop T at least 52 ng or delta 1R at least 5 ng is a rule in status, and the remaining patients to the observational zone. The combination of the level at presentation with absolute changes within 1 hour was chosen because the added value of 1 hour changes and the superiority of absolute versus relative changes. The specific cutoff values were data driven from the initial derivation cohort. The final diagnosis of each patient adjudication was performed by a dedicated group of cardiologists selected for the trial. 2 cardios per patient verified each patient after careful review of results of EKG and so on. Other tests also performed on these patients and a double check in case of doubt. Creatinine, cystatin C, free hemoglobin to quantify hemolysis, and NT-proBNP, radiological imaging, ECG, echocardiography, cardiac stress test, and lesion severity and morphology in by coronary angiography. Pertaining to the patient from ED presentation to a 30-day follow-up. My God, look at all the tests that came in. Discrepancies were solved by discussion with third cardiologist. Inter-rater reliability was assessed by documenting the number of patients with mismatch in the final diagnosis of acute myocardial infarction by two adjudicating cardiologists, which required involvement of a third cardiologist. So if there's a discrepancy, a third guy was brought in. Another study very similar, but APACE excluded STEMI patients. Now that is the cardiological changes. APACE study, algorithm and results. HS Trop T values in patients presenting to the ED with chest pain. There's a note here that's very high NPV for a safe rule out of 60% patients within 1 hour. Definitive rule in or rule out of a total of, I think it says 22% of patients within 1 hour. So the proposed algorithm, 0 hour less than 12 ng and a delta of less than 3. Whilst in the others, the positive side is more than HS Trop T more than 52 ng and a delta of more than 5. Then in the observation rule, excuse me, you have rule out and rule in, and we find that 60% of patients, the NPV was 100%, 23% of patients, N equal to 101, there the N number of patients were 259, prevalence of AMI at 84%, wow. 17% of patients, the N is equal to 76, specificity 97%, positive predictive value was 84%. So this was another study. Did the study have limitations? Question was asked. Yes. They have mentioned 5 from ED patients only, and observational direct study written consent, underestimation of true negative predictive value, and HS Trop T in patients with kidney failure, etc., were excluded in the study because it is known to affect your HS Trop T, people with kidney failure. So here we go, number study 1282. Total is 1282. Ruled out 813, that is 63.4% of less than 12 ng, values of Trop T less than 12 ng, 1 hour delta less than 3 ng, had a negative predictive value of 99.1% and sensitivity of 96.7. That's pretty good. Now 285 patients were in observation zone, the middle one, 22.2%. Prevalence of AMI 22.5%. Okay. 184 patients, 14.4% patients were in the rule-in zone. That means they had it 0 hour more than 52, delta more than 5. Keep this in mind. Positive predictive value was 77.2. Specificity was 96.1. So in the discussions that followed, 4 key points came into focus. It had global representation, not limited to one country, so it was spread over a few countries. They challenged early presenters requiring chest pain onset to be faster than 6 hours as against the 12 hours in others. All patients were included, irrespective of ECG findings, like other STEMI were excluded. So this was a transverse section of the heart. So you've got partial thickness, damage of the muscle in STEMI, non-STEMI patients. Non-STEMI is non-ST. Transverse section of heart, full thickness damage of heart muscle in STEMI. Now this is your findings from cardiology. Okay, you can see the block. See the block. Okay, partial and full. 4 and most important point, stringent methodology measures were taken to make the final diagnosis. Was to have the most stringent methodology and make the educated final diagnosis completely independent of all components of the HS Trop T 0 hour and 1 hour algorithm. Serial testing of HS Trop T complemented all other clinical information, including coronary angiography in the TRAPID AMI, whereas serial testing of HS-Trop T complemented all other clinical information in APACE. That's the other study. So here we go. They also had 7 major findings. The TRAPID AMI had a NPV for AMI in rule out at 99.1%, was perfect and tallied with APACE. The TRAPID AMI, only about half of patients with missed acute myocardial infarction exhibited late increase in HS-Trop T. The other half never showed an elevation. Continue with NPV and PPV in each value in rule out category, rule out category with great degree of accuracy, now universally accepted. So here we go, the 1 hour algorithm, what it does. It diagnoses 78% of chest pain patients in 1 hour versus 3 to 6 hours. That was the old one. Trop T values in acute chest pain patients presenting to the ED. So you've got the 0 hour, it is less than 12, a delta of 3, whilst the positive guys are 0 hour 52 and over, and delta more than 5. So you've got to rule out and you've got to rule in. You can just study what is up there. I don't want to repeat it. Take a look. You've got APACE in 2012. Then you've got APACE 2015. See the changes. And you've got TRAPID AMI. Prospective trial, 9 countries, early presentations, and they were studying 1 to 82 patients. So you've got 63.4 patients. Non-predictive value is 99.1, sensitivity is 96.7. I'm reading the last para. And in the positive, you got 14.4% of patients, and they were using 184, n equal to 184. Positive predictive value 77.2, specificity 96.1. So you can see the TRAPID definitely giving you a better perspective of myocardial infarction. So the benefits, medical value for the patient definitely. Time is life. TRAPID AMI, Trop T 1 hour algorithm is faster than the 3 to 6 hours observed time using the conventional diagnostic approach. That was the previous approach. This accelerated diagnosis is now supported by new 2015 guidelines of the European Society of Cardiologists. Every 30 minutes of delay between symptoms and treatment increases the risk of 1-year mortality by 7.5% in patients with AMIs. Faster time of diagnosis likely to reduce patients' anxiety. So take a look at the table below. So 1 hour and you've got the 4 hour, right? Reduced time for diagnosis, faster rule in, faster rule out. So faster rule in approximate, faster appropriate therapy, faster rule out, reduced ED crowding. And remember guys, in the West, all this is very, very expensive, okay? So now they've devised a method where this helps the doctor to diagnose and treat if it is to be treated. So time of submission, since in 3 hours, you have a diagnosis, okay? Benefit to medical value of physicians, time is myocardium.
I'm not able to see the presentation.
I think it's a little difficult. Can everybody see it? I don't think everybody can see it. They've got their PPTs, ma'am.
No, we've got our PPT, so
Yeah.
we are
Oh, you're
seeing it on
going
that.
from there. Okay.
Okay, all right. Why is it that they can't see
I
the
don't know.
presentation? There's a problem because we've been trying to solve it for a long time.
Which one?
Now we can see it.
Okay.
I don't know.
Now we can see.
Yeah, but tell us please when this happens, because I know what goes wrong with this guy. So medical value to physicians, myocardium, used in conjunction with ECG and other clinical information. TRAPID AMI is Trop T, HS Trop T will allow. Rapid rule out with safety in decision of discharged patients. Rapid rule-in for faster initiation of appropriate therapy. So if somebody's really has the problem with the heart, they'll be admitted and treated. The beauty of 1 hour algorithm is that we can accelerate our diagnostic procedure. It's obvious, right? And this is Professor Mueller, University Hospital in Basel. So you've got the 1 hour and you've got 0 hour and 1 hour. So reduced time of diagnosis, faster rule out, faster rule in. No crowding of the emergency. Like I told you, in West, being admitted to the hospital is very, very expensive. We are very lucky, we can walk in and have our 3D echoes done and all these tests. Over there it's not advisable. That's the reason why NT Pro has got a lot of good results with the guys in the West. So the third benefit is medical value for healthcare system. You can see this? You can see it?
Yeah.
Faster diagnosis with application, rapid AMI algorithm will likely reduce the need for extended observation or repeated testing.
Just the one. Sorry.
Optimize results, resources, saves cost of hospital stay. So guys, this is what is important, especially in the West, And now with Mr. Trump and what he's doing with the medical insurance, I don't know what's going to happen. This is a critical help in the allocation of resources in the emergency room. So same thing below, 1 hour, 0 hour and 1 hour. Time reduced to diagnosis, faster rule in, faster rule out. And within 3 hours the patient is admitted if he or she has to be admitted. So now this is of course Roche, the Roche 1 tube solution. 1 draw, 1 sample, 1 complete cardiac testing is done. Because you have the handheld meters also, right? So you've got the red stopper, the yellow, the blue and the purple. And the Roche complete cardiac testing needs only the green stopper, and that's your heparin. The Roche machines are on the right hand side. The handheld meter is also issued. Roche is the only vendor who gives the option of running cardiac samples from a single tube on any of the Cobas platforms. Shanti, anybody else come up with this? Hello? Okay, we'll go further.
No,
Okay.
not that I am, but I think you can do it on their many things. I think maybe you can do it on what is point of care types. One or two maybe having, but I'm not familiar.
POCT, we have the handheld meter on top. You can see. I think the POCT, HS Trop T, I haven't heard.
It is there, ma'am. The cartridge one. Cartridge one is also student.
Yes. But it gives you HS Trop T?
Yes.
Huh?
Yes.
I know you have the regular Trop T. I don't know about the HS Trop T. The Roche handheld will give you.
The handheld one where you can transfer it from lab to OT and that one.
Yes, right. That's the reason why you have the handheld ones. But HS Trop T courage ke?
Yes, ma'am. It is there. They are giving.
HS Trop T. HS Trop T.
Yes, ma'am.
Which company?
Rose.
Roche is a master. Roche is a master, I agree with you. Now I was asking Shanti if there's anything else in India which mimics this. Because it saves a lot of heartache, a lot of expenses. Roche is a master, but they brought this up and this was given to me to present it all over. I'm talking of years back where I went with it, and was able to sell it. I was able to sell it to the guys. Because the Delhi guys are very, very particular. And to sell it to them, you have to really present it to them in such a manner that they want it. I told you the story of vitamin D. We had the old vitamin D, D3, and we were having trouble. So when we came in with our vitamin D, we took it all over, and we succeeded because they were averaging not even one kit a month. After the presentation that Bala and I did, we took it all over. Shanti, you remember Bala? Bala's gone to Abbott now.
Yeah. Long time is with
Yes,
Abbott.
long time with Abbott. So it's so it's a big loss to Roche. It's a big loss to Roche. He was such a wonderful guy. I have been with him throughout the whole of India. So this is what we presented it at GP Pant, and GP Pant are really very tough, and they eventually, at the end of first month, they bought 12 kits or 15 kits, and there was no looking back. Either they were very reluctantly buying one kit from us. So we could really punch it. Alok Kapoor, Alok is the manager there, regional manager, and he says, "Ma'am, sell it to them because we really need to sell this vitamin D kits." Because our D3 was an absolute failure. It was an absolute failure. Okay. Here we go. Here we go. So this is you can see that little cartridge over there, right? And this is used at the bedside, and it gives you a result. I think it takes 15 minutes if I'm not mistaken. Am I right? Yeah. It used to take about 15 minutes. 15 minutes. And but now we've got, like I said, we've got HS Trop T, and it's much better. The full range. Okay. So Roche cardiac POC Troponin T, quantitative immunological test for the specific detection of cardiac Trop T in heparinized venous blood to use with Cobas 232 instrument. Right. So that instrument is 232. Intended use and extension, quantitative immunological test for specific detection of cardiac Trop T in heparinized venous blood for use with Cobas 232 instruments. Repeat. Test is intended for an early aid in diagnosis of acute myocardial infarction in patients with elevated mortality risk. So people, especially if they have a history, that this becomes very important. So here we have, since it is a Roche presentation, I've let that be. You got the Cobas E411 analyzer, beautiful analyzer. And you've got the Cobas E601 and the 602, the 600. I think the 800 model also carries it, right, Shanti? Now we've got one model ahead of that also. And in the measurement range is between 40 to 2000 ng. Point of care and lab have aligned results. Tests done on POC can later be compared with lab tests. So you also got the handheld machine on the right hand side. You can see it. The limits have been given to you. So Roche solution for patients with suspected AMI. You got the 0 and 1 hour again. Reduced time to diagnose, faster rule in, faster rule out. The Roche POC, point of care, and Alexis HS Trop T offers clinical solutions. So take a look. The positive guys with more than 50, the negative guys with less than 50. So fast track patients with high mortality risk. It's more than it goes to the coronary care unit. The retest all other patients with Alexis HS Trop T. So rule in and rule out, and it saves the patient a lot of time, money, and headache, and expense, of course. So Roche cardiac biomarkers cover all needs, continuity of care. So you got the cardiac troponin T, the old ones, CPKMB, myoglobin, D dimer, NT-pro. And on the other side, you got cardiac troponin T, high sensitivity. Again, you got CKMB, you got myoglobin, your D dimer, NT-pro, and HS Trop T and more for acute coronary symptom to heart failure. Of course, this is what Roche has, and they're very happy. And I have got this very lovely saying by Maya Angelou: "The happy heart runs with the river, floats on the air, lives to music, soars with the eagle, hopes with the prayer." I hope you liked it. That's the last slide.
Yes.
Shanti, your critique, you want to add something? Because you brought it up last time and they were telling me, ma'am, let's go with this.
Yes. I think usually nowadays more Trop I is done than Trop T. If you have exclusively a Roche instrument,
Mm.
then people do Trop T. But the preference by cardiologists as a whole
Yeah, yes,
is
I agree.
Trop I.
Yeah, yeah. I always thought a tropi was something that was, it guided the physician to say, be careful.
Yes.
This
And
is,
it is not that troponin increases only as you mentioned last time in myocardial infarction, but
Kidney-
myositis,
kidney-
whatever.
kidney.
Wherever there is a stretch or something to the muscle.
Mm.
And actually in India as such, no, I don't think many follow the dictum of a baseline and then 1 hour and then 2 hours, which is actually a dictum in the West. But here we go by one, and because I think the eco and angio are easily available
Right.
in India, not
Right.
like the US.
Right,
So you
right.
have to wait for hours or days to do anything. So I think they just take one sample, go with the clinical history, and then push the patient to angio if necessary,
Mm.
or just follow up with eco, etc.
Mm.
But getting a eco done in Western countries, especially the US, is a big problem.
Mm-hmm.
So I really don't think in India we follow immediately 1 hour, 2 hours, unless somebody is working on any paper or research. They take the baseline, and unless absolutely necessary, they don't repeat the second and third hour.
Okay. Yes.
It's a lot of money also.
True.
It's a lot of money to do 3 drops in a matter of 6 hours and all. It is a lot of money, especially in corporate hospitals.
But I believe, I'm hearing that heart problems have become money-making machines in India. Is
Yes.
that true?
That is the tragedy. Everybody is pushed into an angio. Everybody is pushed into a admission.
Have a bypass done, have a angio done, and I'm hearing tales, Shanti, over here, I won't mention names, that the stents have no medication. They tell you, I'm putting a medicated stent into you, and they found out no effect.
Those medically aided stents are much more expensive than ordinary stents.
Mm. Mm.
No, ma'am, I know of a person, one of my friend, they had said that he's got a stent done and they did it. And then in just 2 or 3 months, he had another attack. And then he went to another hospital and they realized he had not even put the stent.
Oh my God. Oh my God. Oh my God. Yeah, I'm hearing tales and it frightens the hell out of me. It frightens the hell out of me. A lot of it kept appearing on YouTube and people talking about, be very careful. Anybody else with any inputs? Parul told us something. Meena, Pariza, Rohina, have you heard of anything? Rohina, what happens in Kuwait? All honest engines? Unmute. Unmute karna.
Yeah, clear.
Yeah.
Okay, you can hear me. So I am not very sure about the cardiac markers because I'm not dealing with that. But our company, basically, we have this machine which we give to people who need it, small labs and all. Here, there's a very big problem right now with small labs, the private labs, because there's something called AFIA insurance, which the Kuwaitis have, which they would, get a good deal with all the private labs. They would have to only pay about 5%, 10%. Now, since they removed the AFIA insurance, these people are not going to the private labs at all. So the private hospitals and clinics are really suffering, really suffering. And when I used to go there earlier, I could see at least 50 people, at a time. But now I am not seeing even one. It's that bad. So they all go to the government hospitals for free Medcare or whatever they need to do, except for when it's surgery time and all. For that, they will approach the private hospitals. So labs are really suffering. they'll do their tests also in the clinics, in the government clinics. So what we are doing is we're trying to get certain labs to take these point of care machines. We have something called immunometer. It's kind of like a machine which does this D-dimer, troponin, BNP, cardiac panel. So it has these integrated, but it's also called micropoint. I'm not very sure where it is from, but yeah, this is the machine that we try to provide to people. And besides that, it was very interesting. Your lecture was amazing. It was an eye opener for me. I can probably use some of this knowledge to give to certain doctors. Doctors over here are they don't want the knowledge. They just want to give advice. And on what basis? That's why I come to India to do my tests. I believe there's a lot of scope in India rather than outside, like in the Gulf also, in Kuwait especially. When I approach doctors, I was approaching them for even NIPT, like what you were talking about earlier.
Mm.
So many doctors, they don't know. I'm talking about the lab managers, not the gynecologists. They know about the test, but here is again NIPT is like for the private hospitals, private clinics. They are doing the send out. They're doing it to TDL labs in UK, or they will look at the med lab and sends it to Jordan. Now I am introducing this to send out for Hong Kong. This is our take right now, doing an IPT for these people because it's a need of the hour. Many relatives get married together and they have to do it because in a family you'll always find one child who is differently able. So, yeah, this is what's happening in Kuwait right now. I'm struggling to find uh, a new base where we can actually introduce. And I would like to get things from India, knowledge base to make them understand. You know. So these lectures really help me
But
so that the
Rohaina, since you're
just
talking of this, you came in a little late. I'm talking to girls over here. So January we're introducing this pregnancy-related tests, dual markers, triple markers, and
that's
a
what
lot
they're
many
asking
others.
here.
Lot many
Yeah, that's
others.
what they're asking over here too.
So
So here, these kind of tests, the special tests are always sent out to specialized labs, outside. So we are in touch with BGI, and BGI has maximum number of send outs for NIPT. So here, no one's actually doing NIPT; it's always being sent out.
Nazneen, what about you in Dubai? Nazneen,
Man, troponin one. Man, troponin K, troponin I, high sensitivity troponin
mm,
K, everything is being used. Mostly that 8232 is a very commonly used equipment over here. In the lab also, in the ICU also, in the, what do you say, in the OT also sometimes they are keeping all these machines ready along with blood gas analyzer. And mostly, basically, the treatment follows that we should know that how myocardial infarction is actually differentiated from the STEMI and the actual infarction because infarction occurs for many reasons. So here there are two steps. They do ECG and STEMI diagnosis with ECG and Trop T. So, and of course, we have to clinically correlate also if the doctor is knowing the history, what is the history of it, because sometimes myocardial infarction can't, all elevated Trop T is not myocardial infarction, because it could be due to sepsis, then kidney failure, then what do you say, there was this pulmonary embolism, all these things also lead to, muscle damage. So mostly this high sensitivity probe C probe the one which Roche has been doing this cartridge is very good to rule out immediate along with the ECG. So that's why this test has become very well known. Is it when you don't have the history, it really gives you the boost to go ahead to repurgation. With the repurgation treatment, you can immediately start. That is why the readings are also faster, and that's why it has a greater momentum and it has been building very fast this day.
Yep.
And this equipment also.
Okay, that's wonderful. I'm glad that you all appreciate what we give you. And like I said, I think Nazneen, were you here when I said that on January I want to present the pregnancy related dual markers, triple markers, toxos, PCT, and stuff like that. And like ma'am says, the hormones, both
So
the reproductive
critical
hormones.
and moreover, previous looking for. Okay.
So we will start. We will start in January. Okay.
Sure.
But we are going to skip that 16th. We are going to skip that 16th